Welcome to the after break session. I'm Miriam Bredella, I'm from Boston, and I will talk about the effect of fasting on human bone marrow adipose tissue. And you might think, how can you talk for an entire talk on fat within bones? So let's talk about first about how our bones are composed. So within our bones, you have the trabecular bone. These are these little lines here on the graphic. And they are filled, the spaces in between are filled with bone marrow. Our trabecular bone is important to give us architectural support, mechanic support, so we can stand upright. It's also important for deposit our minerals, calcium and so on. And then the space between these trabeculars is filled with marrow. There is the red marrow, which is red on the graphic, and this is full of our red blood cells, also called 𝗵𝘃𝗃𝗀𝗀 marrow. It contains red blood cells, white blood cells, or platelets, and there's a lot of vascularity. And then we have the fatty or yellow marrow, which is yellow on the picture there, and that contains adipocytes, so fat cells, and there is very little vascular supply. So it's very interesting. In our body, the marrow composition changes. So at birth, all of our marrow is red or 𝗵𝘃𝗃𝗀𝗀𝗀. On the left, you see the marrow in the femur and the pelvis. It all contains our blood-forming cells. And then during puberty, there's a really rapid conversion from this red or 𝗵𝘃𝗃𝗀𝗀𝗀 marrow to fatty marrow. And then over time, you see there's more and more fatty marrow. And in the adults, we typically have in our long bones a lot of fatty marrow. There can be a little bit of residual red marrow, as you can see there in the femur. And we can see the same on MRI. So I'm a radiologist. You will see some MR images today during the talk. So here you see the pelvic bone from the front. And on this sequence, these are T1-weighted sequences where fat is bright or white. You can see this here. The subcutaneous fat is white, and in the marrow, red marrow is sort of grayish, and then if it becomes more and more fatty, it gets whiter and whiter. So you see in the 1-year-old, everything is still 𝗵𝘃𝗃𝗀𝗀𝗀𝗀, and then in the teenager, you can see that there is still 𝗵𝘃𝗃𝗀𝗀𝗀𝗀𝗀 marrow here, but the ends of bones, the epiphyses and the diaphyses have already converted, and then in this 50-year-old, it's almost all fatty with some small areas of red marrow. In the spine, which is really interesting because there are really two types of fatty marrows that we discovered, but in the extremities, you have a lot of fatty marrow, especially in the distal aspect of the extremities, but in the spine, what we call the axial skeleton, it's a little different. You can see in the 4-year-old, it's all red marrow, and then the MR images, you get lighter and lighter in gray shades, but we still have a lot of red marrow even in the adult patient, and then in this 83-year-old, it's almost all replaced by fatty marrow. So what is now the function of marrow fat? So we always, for the longest time, thought that marrow fat is just an inert fat depot that really fills empty spaces that are left if you have osteoporosis or bone loss. The spaces in between the bones need to be filled with something. So we thought, oh, it's just a filler for empty spaces and really has no function. But over the last 2 decades, we learned more and more about the function of marrow fat. And we also learned that it's very different from your white fat, like your subcutaneous or visceral fat or brown fat. And now we found out that marrow fat actually functions as a secretory or metabolic organ. We found out that marrow fat can actually secrete hormones and cytokines, and that marrow fat plays a very important role in skeletal homeostasis, meaning it is really important for your bone health, depending on the hormones and other substances it secretes, but also for energy metabolism. And what is really interesting and exciting is that marrow fat responds to nutritional challenges. So if you either eat a lot or you fast, it has changes in your marrow fat, and we will talk about this in more detail. So as I showed you on these MR images earlier, the distribution of marrow fat is it's quite different. It's not distributed uniformly. You have more marrow fat in your arms and legs, and we actually discovered 2 types of marrow fat. The one in the extremities and the distal part of long bones. It develops very early after birth. That's what I showed you in the teenager. And it gets rarely depleted. It means even if you have a lot of challenges, nutritional challenges, fasting or high feeding, or in cancer, chemotherapy, this constitutive marrow fat actually doesn't really change much and stays the same, and we discovered that it has higher unsaturated fatty acids within the marrow fat. And then there is the more proximal, we call it also regulated marrow fat, that's in the axial skeleton, the spine, in the proximal parts of the long bones, also in the sternum, pelvis. And these marrow adipocytes are very responsive to any stresses or nutritional challenges. They can quickly increase or decrease, and this has lower unsaturated fatty acids. And we think that these two types of marrow fat may be important for the effects on marrow fat on bone biology, but also hematopoiesis and energy metabolism. So we can quantify marrow adipose tissue. We just saw it in the excellent talk before the break using MR spectroscopy, where you put a little voxel or an area in the bone of interest, and then you get a lipid peak and a water peak. You calculate the area under the curve, and then you get a lipid to water ratio. But we can also assess the composition of the marrow fat. We can look at the amount of saturated and unsaturated fatty acids. And it's very interesting. In the marrow, it's very similar to what you eat, or in the peripheral fat. A lot of saturated fatty acids are actually bad and have been shown to increase fracture risk. And more unsaturated fatty acids are better. So this is just an example how the marrow fat composition changes from the spine. So this is a lumbar vertebral body all the way on the left. So and then you have the femur and tibia. And so you see the more distal you get in your skeleton, the more fat you have. So now what is the function of marrow fat? This is from a review we recently published, where we explain that the interesting or very unique feature of marrow fat is that it can expand. Not that the bone gets bigger, but you get more adipocyte under certain conditions. For example, with high caloric feeding or aging, the marrow adipocytes increase and they secrete a lot of inflammatory cytokines, for example, tumor necrosis factor or interleukin-6, which then activate osteoclasts. So these are the cells that resorb bone, and they suppress the osteoblasts. These are the cells that lay down bone. So and this can then lead to bone loss. It also has function of energy metabolism. We will talk about this. And very interesting, something we've just discovered a couple of years ago, there is more and more interest now how these marrow adipocytes also influence the growth of tumors, multiple myeloma or lymphoma or metastases within the marrow. And we will go over what happens during high caloric feeding and fasting, but there's really this inflammatory phenotype, and this can also then cause your metabolic syndrome, your heart disease, and diabetes, all coming from the marrow adipocytes. So we actually wanted to look at the role of marrow adipose tissue in metabolic risk and bone health, and we studied patients with obesity who had type 2 diabetes, because patients with type 2 diabetes are really interesting. They have very high or higher bone mineral density or normal, but they are still at an increased risk of fractures. So we thought maybe marrow fat might play a role in this. So we studied patients with obesity we had two groups. One group had type 2 diabetes and the other group was equally obese, same age and BMI, but they did not have diabetes. And we found that the patients with diabetes had higher bone mineral density. That's what you see here on the graph, and this is obtained by QCT. It's a very accurate technique to assess bone mineral density. But they also had more marrow fat, which is really interesting because people often think that the marrow fat is sort of the reverse of your bone density. Once you lose bone, you have more marrow fat. But this actually shows that you can have both. You can have high bone mineral density and high marrow fat. But they had more or lower unsaturated fat or more saturated fats within their bone marrow. So probably what you would expect in their peripheral blood, because they had diabetes. So this was also reflected within their bones, within their marrow fat. They had more saturated lipids and less unsaturated lipids. And interestingly, marrow fat correlated with HbA1c, which is your marker of glucose control. So this really suggested that marrow fat is not just a biomarker for bone health, but also for your metabolic risk. Now we wanted to see what happens to marrow fat if you lose weight, and we had several models of weight loss. One was weight loss after weight loss surgery, bariatric surgery. And we're having a big study in adolescents with severe obesity who undergo weight loss surgery. So we studied these kids before and 1 year after weight loss surgery, and we also had a group of adolescents that were equally obese, but did just lifestyle intervention, diet and exercise, and followed them also for a year. And we performed spectroscopy of their bones to look at bone marrow adipose tissue, and we also did QCT to look at their bone mineral density. And this is just an example of a 17-year-old before and 12 months after weight loss surgery. And you can see on these CT images, usually the BMI pre-surgery was in their 40, 45, 47, I think was average. And they lost about 30 to 35 kilos. This patient lost 35 kilos. But they were still obese, so it was still, they had a BMI of 35, but you can see there was a lot of reduction in fat mass. But also you see their bone mineral density before and after, and there was a significant decrease in bone mineral density. So what happened to their marrow fat? So we could see that the peripheral fat went down, their bone mineral density went down, but interestingly, their marrow fat went actually up. So that also shows us that marrow fat is very different from the peripheral fat. So their marrow fat went up, bone mineral density went down, so that shows that weight loss surgery is not as good for bone health as maybe for your cardiometabolic risks. But there are several mechanisms in weight loss surgery. There's malabsorption, there's less weight bearing because you're losing all this weight, so there's less stress on the bones. So here is a different patient. I told you that I'm going to show some MRs. This was an 18-year-old female runner with right hip pain. I don't think there are any radiologists in the audience, but just show you there is something abnormal in the femur here, and there is a line, so this was a stress fracture. And I just want to show you that this person doesn't have a lot of subcutaneous tissue and had maybe a little more marrow fat than usually, and this was a patient who had a low BMI and had anorexia nervosa and had a stress fracture. So we actually found that women with anorexia nervosa have higher marrow fat compared to normal weight women that are matched for age and sex. And also that in women with anorexia nervosa, the marrow fat inversely correlates with bone mineral density, meaning the more marrow fat you have, the lower your bone mineral density, and also the body fat. And I just want to, before I show you the next case, go back and show you, although this woman had anorexia nervosa, she still did have some subcutaneous fat, which you see here in white. Not much, but she still had, so she was not as sick. And her BMI was 17.5. Now I show you a different case. This is also a woman who came in with heel pain, and MR was obtained to rule out a fracture. So you're not radiologist, so I don't expect you to see, but there is something very, very abnormal with these images. Just to show you that this sequence here on the left should look like the small image on the top, so the fat should be white. And on the image on the right, which an image where we suppress the fat, everything should be black. So in this case, it's almost reversed. So we thought this is a technical error. The technologist screwed up the acquisition. So we called the patient back to repeat the scan, and it looked identical. So this patient had severe anorexia nervosa. Her BMI was, I think, 15. So what we saw is it's called serous atrophy of bone marrow or gelatinous transformation. So in states of extreme cachexia, so very, very low body fat in patients with severe anorexia, AIDS, cancer, or after chemotherapy, the marrow fat can actually be metabolized, and the body typically holds on to the marrow fat until sort of as a last resort. That's why we have in the patients with anorexia nervosa, they have high marrow fat. But once they lose so much weight, the body actually uses the marrow fat and metabolizes it, and then it gets replaced by this gelatinous fluid, and that if you do histology, it looks necrotic. The problem on MR then, that the marrow fat looks almost identical to water, and also the surrounding soft tissues. That's why it has this unusual appearance. And the problem is that the complication is that there's a high risk of fractures because of the underlying condition, but now also the marrow is completely replaced or screwed up. But then you cannot see it on the MRI because it's obscured by this abnormal signal. So we actually got an X-ray, and she had 2 stress fractures in her calcaneus, and we were not able to see those on MRI. So we learned so far that long-term nutritional deprivation impairs bone health. So the one after weight loss surgery or long-term and severe anorexia nervosa. So now I would like to spend the rest of the time to talk about our study we did a couple of years ago. We completed it and published it, so I can talk about it, where we wanted to look at the function of marrow fat after acute nutritional challenges. And this was a very, very involved study where we recruited 23 healthy volunteers. They were healthy, they were normal weight or slightly overweight. They were admitted to our hospital, to the clinical research unit, for 10 days. And for a high caloric diet. We'll talk about what this was. Then after 10 days, they went home to eat normally for 2 weeks. And then they came back again to the hospital for a 10-day fasting study. It's not Buchinger, it was in the hospital, and they basically got nothing. That's it. We came once and walked them around a little bit, so they had some exercise, but it was not the nice morning walks, and there was no yoga or anything else. And no soup, and no juice, and no honey. So a 10-day high caloric stay, the goal was to increase their body weight by 7%. And it counted to, in most patients, was tailored to each patient, of course, but it was about 5,000 to 6,000 calories a day. So then they went home, and we didn't really instruct them what to eat once they went home, and they just did have the regular diet, and then they basically came in and got nothing, a multivitamin. What is really interesting is that we had 2 patients who could not complete the study, and I would like to get a poll here. Who thinks that they couldn't do the high feeding, or who thinks they couldn't do the high feeding? And who thinks they couldn't do the fasting? Very good. I think more said the high feeding. It was that they could not eat the 6,000 calories, and they had to stop. So, but everyone was able to complete the fasting, and I met with all of them, and they said the fasting was much easier. So we did a lot of studies in these because it was so involved, and we recruited them. So we did, of course, MR spectroscopy to assess bone marrow adipose tissue because this was our primary outcome. But we also did an MRI to look at body composition. We also did DEXA to look at whole body lean and fat mass. Then I did bone marrow aspirations in actually a subset of patients. We did not do 4, we only did 2. One group got them before and after the high caloric diet, and one before and after the fasting. I don't know well, there are some clinicians here. So bone marrow aspiration, it's not nothing, but it's also not super complicated, and they got reimbursed for it. So we had 9 who had marrow aspiration before and after the high feed diet, and 11 after the fasting. And then we did very complicated analyses. We looked at the marrow serum, and then we also did qPCR and look at gene expression of the marrow adipocytes and looked what do they express. And we looked at some inflammatory markers, TNF-alpha, resistant, plexin D1, and as you can see this here. But these were basically, we were really interested in the inflammatory markers. And then we also, of course, looked in their blood and also focused on some hormones, but I will focus this talk on the inflammatory markers. Then we were also interested in looking more at detail at bone microarchitecture. Most studies that I showed you earlier, they were bone mineral density by QCT or DEXA. This is typically what you do to SBMD. But we have this extreme CT where you can actually image the bone at 80 microns. And we can do the distal tibia and the distal radius. And so you can get very, very detailed assessment of trabecular and cortical microarchitecture. But what you also can do is get strength estimate by something called finite element analysis, where you can get the true strength of materials. So here are the subject characteristics. Now I have to turn around because I'm not wearing my glasses. But you can see what is really interesting. We had, so here 23. The total number you see here, and then we had 13 men and 10 women. They were the same age and BMI, but even having the same age and BMI, what's interesting is that the women had more subcutaneous tissue here than the men, and the men had more visceral fat. even with the same BMI. The visceral fat is the bad one. And women also had more extremity fat, so the fat around the buttock and thigh area, which is actually good fat. It's thought to be protective against bone metabolic risk, but men had way more muscle mass. And men had more marrow fat than women in their spine and in their femur. So this is now what happened after we did the high caloric diet, the stabilization, and the fasting. So after the high caloric diet, patients lost about, or patient subject, 6.3% of their body, gained 6.3% of their body weight, which was a little less. We wanted them to gain 7%. Interestingly, they lost about 2%, but during the fasting, they lost 8%. So in the end, they came out with a net weight loss, which they liked. That's why the reason why we had the high feeding first is that if we had fasting first, we were afraid they would not come back for the high feeding diet because they would be so happy with their new body weight. So that was the reason for the order. And here you see all the fat went down and also lean up with the high caloric diet, and then it went down, and actually also on the fasting visit it went down. So this was the body composition. Now let's take a look what happened to marrow fat. Interestingly, marrow fat went up during the high caloric diet. It's not surprising, you eat a lot of fat, so why not in the marrow? It went down significantly during the stabilization period, and then it went up again in the spine during the fasting. In the femur, it was different. It went actually up during the high caloric diet, then it went down again, and then it went down a little bit during the fasting. But in the spine, it was really significantly up in both instances. This is just an example. Here you see one subject where you have the marrow on the left before and then after on the top right after the high caloric period, and then on the bottom you see it before and after the fasting where it goes up again. These are just some MR images, and this is just an abdomen, an axial image for the abdomen at baseline, and this is someone who gained 6 kilograms during the high caloric period, and here is just the mean of everyone, and then you see the marrow fat, how it goes up. And this is after the stabilization period. That's the same person who lost then about 2 kilograms just going back eating normally, and the average was about 2.7%, and then the marrow fat went down again. And here the fasting before and after, this person lost 8.9 kilograms, and the mean change was 8.8% of their body weight. And here is the marrow going back up again. Okay, so what was really interesting, we looked at the gene expression of inflammatory markers within the marrow adipocyte. So during the high caloric diet, we found actually that in the marrow serum, the resistin, which is an inflammatory markers, increased and decreased during fasting. The other inflammatory markers you see here, TNF-alpha and others, they significantly increased during the high caloric diet. So the marrow adipocytes changed their gene expression to produce a lot of inflammatory markers. Interestingly, during the fasting, the TNF-alpha went down again, and for the other inflammatory markers, there was no change. So this was something really interesting because it shows that maybe the origin of what we are seeing in the peripheral blood comes actually from the marrow adipocytes. And the interesting part is that during the fasting, the TNF-alpha went down, while in the peripheral blood, this is very busy, but some of the inflammatory markers went actually up during fasting in the blood, but in the marrow, they went down. So here we just see, I want to highlight the inflammatory markers here, TNF-alpha and CRP went significantly up during the high caloric diet, and then only the CRP went up during the fasting, and there was you have to look here, the GDF-15, which is another inflammatory marker, went up. So it wasn't really the same during the high caloric feeding and the fasting. Now I would like to draw your attention to the bone markers. CTX is a marker that induces bone resorption, and P1 and P is a marker that is for bone formation. So the formation went up during the high caloric feeding, that's expected, and resorption went down. But during the fasting, actually resorption went up and bone formation went down. So we thought, well, this is expected because there are several studies that have shown how you get loss of bone mineral density after caloric restriction. So this is really a really important topic because there is now more and more interest in doing intermittent fasting or fasting, and is this bad or good for your bones? So as we have seen, there is increased bone loss and increased fracture risk after weight loss surgery. And there are also studies that have shown that after long-term caloric restriction, for example, the calorie studies, this is a study that is a 2-year study where they had 25% continuous caloric restriction. They all showed that there was a marked decrease in bone mineral density and also, of course, in anorexia nervosa. But no one knows really what are the short-term effects of caloric restriction in bone, and not just bone mineral density, but bone microarchitecture. So I'm really excited to show these findings because we found, contrary to our hypothesis, that in the distal tibia, there was an increase in bone microarchitecture. So here you see the change in tibial total volumetric bone mineral density. There was no change during the high caloric diet or the stabilization period, but during fasting, there was a significant increase in your volumetric bone mineral density, which is a very accurate assessment of BMD. And also in the cortical bone, there was much more cortical bone mineral density. And also trabecular thickness increased, and the strength estimate, failure load is one of these estimates, increased. This was in the distal tibia. We did not see anything in the distal radius. So we thought, wow, is that really true? But we have done since experiments in animals and found the same, and there may be a sex dimorphism, that it's different for males and females. And also the cortical or trabecular bone, our numbers are too small, so we didn't see it in our patients. But I thought these were really interesting and exciting findings. So to conclude, take-home points, marrow adipose tissue is a really dynamic fat depot. It can be quantified by proton spectroscopy, and we can look at the composition and the content. We can do it during chronic, long-term, or short-term nutritional challenges. And we have found now an increase in marrow adipose tissue following short-term high caloric feeding and fasting, but there is probably a different pathophysiology underlying these changes. What is really interesting from our study is this high caloric feeding produced an inflammatory response within bone marrow adipocytes, and these rise in inflammatory markers might contribute to the long-term sequelae from high caloric diets and the metabolic syndrome and your cardiometabolic risk. Interestingly, there was no increase in these inflammatory markers within bone marrow fat after fasting. There was actually a reduction in marrow TNF-alpha. And short-term fasting after the high caloric feeding and healthy individuals improved bone microarchitecture of the distal tibia. I say specifically after high caloric feeding because we don't know what happens if you just do the fasting. Again, this study has the limitation that the design was that they were eating a lot before and then having the stabilization period. So we cannot say whether we would have seen the same results just after fasting. But this is just to acknowledge our funder, and I would like to thank you for your attention.